4 ఉన్నారు సచిన్లో 4 ఉన్నారు. వాడ ఎస్ స్టాటిక్ ఎక్స్పెక్టేషన్ చెప్పేసి స్టాటిక్ ఎక్స్పెక్టేషన్. అవును సార్. మల్టీపోటెంట్. డోరేట్ దింగుతాడు. చెప్పాలి. Yes, sir. Good morning, sir. These are the cases done in Unit 1 this week. 78-year-old female with 4.5 months post-op status, supramalleolar fracture of the right leg. This was the X-ray on admission 4 months ago, and when she came to the hospital for the first time, she had a supramalleolar fracture, for which we have done plating for the fibula and K-wires for tibia. We did K-wires for tibia because there was a lot of swelling, sir, and the patient is also a known case of breast cancer with bony metastasis. So we thought we can try fixing with K-wires, the tibia, and then we put a cast post-operatively. Now 4.5 months later, she presented with, on follow-up, we saw that the tibia was in varus with irregular callus formation. The fibula seems to be properly uniting. So now we've corrected the deformity, sir, for the tibia, and we've done locking compression plate with bone grafting. Yes, sir, after 4.5. Yes, sir, all the stability was good. Yes, sir. Yes, sir. She's on chemo and radio, sir. Both. No surgery. This is అదే బ్రెస్ట్ క్యాన్సర్ సర్జరీ తీసుకోలేదు సార్. The first time we sent, sir. She didn't say anything conclusive. రాలేదు సార్. Shows occasional lytic lesion, mixed lesions వచ్చింది సార్. Bone spine. Yes. Complete. Pet. Yes, sir. Yes, sir. Yes, sir. Poor muscle mass. Yes, sir. 78. "28-year-old male, sir, with closed lateral condyle fracture of the right femur. The patient had a history of road traffic accident, skid and fall from the bike." So these are the CT films. It's
See that there is a osteochondral fracture there. That's what the purpose is below the, yeah. You can see that. Yeah. Even this also you can see from this lateral side. Yeah, right. This also you can see. This is what so always fix this. So always fix this. What is that? Right. Hmm. Open reduction. Right. Right. Yes, yes. Next.
30 years old male with closed middle third distal third junction, both bones have fracture of right leg, sir. We have done closed reduction internal fixation with ILN. Sir, by doing this, actually we can treat it conservatively by small
This is
correction of angulation, but
contact is there.
by early weight bearing we can't.
Why you
That's
can't
why we
do?
had fixing.
Submient or functional cast base.
By operating with nail, we can mobilize for after 2 days
Next
or immediately we can.
next day you can do not. Francis fracture is there, you can make him out next day after
day.
putting it. Otherwise, no. But this can be treated conservatively. This is what the functional cast base, you know.
Sir,
It'll-
we need
It'll correct by itself
we need to
once you
correct
put it.
the
Yeah.
We need to correct the.
Once you mold the. No, no, because angulation is this much, sir. While putting the cast, you can just mold it. Yeah. Pitching there, no. They have not seen wedging being done.
We didn't see it, sir.
Cast brace, you have seen applying cast brace? Functional cast brace, no.
Wedging Jubilee.
Wedging, you have not seen. You only want to surgery.
Walking cast. 15 dog.
You kiss it. It is so much.
70 years.
You're making me walk next day?
Sir, actually it's a suprasyndesmotic and too far.
If it is at the fracture site, you have to fix it, otherwise no. The fracture is away from that, there is no need to do it. Suppose had it been fractured here, definitely I have put this also. That's what the reason is.
So,
It need to be fixed.
Yeah.
Unstable. Sharing device. Weight
net
sharing.
sharing. Sharing, sir.
Sharing.
Both. Next is both.
Sharing.
Mm. 70 years old female with introduction fracture of right femur, sir, with 10 years post-op status of DHS of right femur, sir.
Done here or somewhere else?
Somewhere else, sir. We have done close reduction internal fixation with short PFM, sir.
A 23-year-old male with 1 year 7 months post-op status, grade 3B compound distal femur fracture with LCP in situ, sir. We have done implant removal.
Removal. Show that. Right. Is it varus or valgus? Yeah. Mm.
There was no signs of infection, sir, and
7 months old, right?
1 year 7 months old.
Yes.
It was. The ROM flexion was around 40 degrees.
Clinical photograph లేదా తెలుస్తుంది.
Yeah, we could have tried to break the adhesions under anesthesia. Fixation was improper.
Right.
Yes, sir.
ఇంకోపరేట్ ఇక్కడ డ్యూయల్ ప్లేట్ ఏజ్ ఎంత ఏజ్
Yes, sir.
రైట్.
This is a 23-year-old male with cerebral palsy, sir, spastic monoplegia, upper limb, left upper limb, sir. When we examined the case, his attitude was elbow was in flexed position, the forearm was in pronation position, wrist is in flexion, fingers are also in flexion, sir.
So deformity is what? What deformity can describe seeing the patient now? Flexion of the elbow, flexion of the wrist, pronation. What about the thumb? Is it in palm or not? All these are thumb in palm always there, but it's there, it's not there. Thumb outside only. The commonest deformity is only flexion of the elbow, flexion of the wrist. Thumb in palm deformity is very severe, correct. Because it looks like only the flexion of the wrist is more and elbow is not that much.
Yes, sir.
Right?
Shoulder is,
You're able to move.
yes, sir, he is able to do, sir. Okay.
So is it Walkman's contraction?
No, sir. There was no
No.
history of trauma which is associated.
Not clinically. How to make out
Clinically looks like a Volkmann ischemic contraction, but there is no history of trauma. That is why.
trauma need not be seeing the patient? Can you say it's a Walkman's contraction or not? Walkman's, can you correct?
Yes,
This
sir.
is corrected passively.
Yes,
Did you see it or not?
yes, sir. Yes. We try
So-
to correct it.
Show that passive correction of the wrist as well as fingers. That will show that only that differs from Walkman's contraction.
IP joints. Yes.
Yeah.
Okay.
What about the flexor pronator band? Is seen taut or not?
It's taut, sir. Taut, sir. Taut, sir.
Show that it is there.
Not
I have point here. See all these things there.
లేదు.
Hmm. Hmm. Just
They are supple, sir.
showing the surgery and
Every
then
joint is supple only.
is not
All
enough.
joints are supple. Supple. Sir, so we have done tendon transfer. We have transferred FCE to ECRL and ECRB to only correct wrist flexion. This is a first procedure. The second procedure, we will plan for a max page operation so that the elbow flexion and the forearm pronation can be corrected, sir.
No, not that much, no flexion. That's what I said. Flexor pronator is taut, you can make out by just extending it. If it's so taut,
Sir, carpi radialis
so
longus and
how to
brevis.
identify ulnaris? How to identify the dorsum of the wrist tendons? Do you know? You are
Yes,
there.
sir. Yes, sir.
What can I explain now?
We should flex the wrist and ulnarly deviate it. The tendon which becomes taut is the FCU, sir.
Hmm.
And ECRL and ECRB extension of the wrist.
But
We can just pull the tendon, sir.
where is FCU inserted? How to make out this is FCU?
FCU is inserted on the pisiform, mucophymate and the base of the fifth metacarpal, sir.
Right. Unless you identify that, release from there, then transfer to the dorsal side.
Yes, sir.
So dorsally, how to identify which compartment is the ECRB, ECRL?
Once we have exposed of the tendon, sir, we can just put a artery below the tendon and we can lift it up, sir. The tendon and we can lift it up, sir.
ECRB, ECRL says.
Second and the third. Second and third.
To make out that lysis tubercle is there, can you by side?
Yes, sir.
That's
yes,
what
sir.
right.
Yes, sir. We have made a interval between the
Subcutaneously you have done, no? What
Yes,
no
sir.
interval there?
yes, sir.
Transfer this.
Dorsal, sir. ECRL and ECRB, sir.
Wrist only. Yes. No.
Yes, sir. That.
But true extents of wrist are only these two. ECRB, ECRL. Right? He knows.
Second compartment.
Right.
We have post-operatively fixed it in an extension cast, sir.
How much dorsiflexion? You
Sir?
show that, no?
So
Mary? Wrist. How much wrist extension is there? Dorsiflexion.
roughly 20 degrees. is
Yeah.
there.
30.
So, okay.
How to make out? Side of the
Sorry.
also. Yeah.
Sorry.
30 to 45 degrees should be the extension. Otherwise, no point in doing it.
Okay,
Well, the movements are finger, no, normal, no?
Present, sir.
Nothing is
present,
there.
sir.
Thumb extension is there.
Yes, sir.
Right. No. It's only ulnar lesion, not here.
Knuckle bender is for ulnar now, sir. In order to flex the MCP, first we will maintain the cast for 6 weeks, sir. After that, we'll remove and we'll start ROM. Active.
What you have to give is extension orthosis for wrist as well as fingers.
Okay.
That should be given. That is dynamic. Dynamic extensor orthosis for wrist as well as fingers.
Okay.
Right.
At least 6 months. A 24-year-old male with intracapsular fracture of left femur, sir. We have done close reduction, open reduction, internal fixation with cannulated cancellous screws, sir. Close, sir.
Close reduction.
Close reduction, sir.
How to do it? Close reduction?
We have put him on traction table, sir.
No, tell me the methods of reduction of IC fracture.
Leadbetter technique is one. One is Leadbetter technique, sir.
Explain how to do it. I don't know. How to reduce the IC fracture in young adult. Each step you are supposed to know. Why you are doing flexion, why you are doing extension, why you are doing rotation. Is it Whitman's technique or Leadbetter technique?
Yes, sir.
No, you are there.
Yes,
Explain now how to do it. Manipulation is important. Don't think it's
Sir, but we do it. Do we really do it in real life? Because it has these techniques. They have a higher risk of avian of the head of the.
who said you without also a higher risk is there. Putting a there also is a higher risk for avian. Who said it's there? Unless you manipulate properly, unless reduce, you can't put a screw or a nail there. That should be there. Each step you are supposed to know why flexion, why abduction, why internal rotation. What happens to these?
24. Fresh, sir.
Fresh fracture only.
1 day, sir. This is biplane double support screw fixation. Yes, sir. This is better, sir. Yes, sir.
Show the first X-ray. First X-ray, right. This looks to be only nice only, no? I can put a DHS and leave it. Why so many screws? Ideal young fellow, 24 years, you can just put one DHS, that's enough. This many screws, you may spoil the blood supply to the head. Right.
Lowell says lines.
Yes.
Yes, sir. Reverses, sir. Sorry, sir.
Right.
Yes.
Our things index.
Subcapital. High chances of AVM. Is subcapital.
Yes.
Subcapital or transcervical this is?
Sir?
Is it subcapital or transcervical?
It's subcapital, sir.
You can see
I
this
think 2 lines are seen, sir. 2 fracture lines are
subcapital
seen.
just below that. No, it's transcervical only. See, you can see here. Right? Subcapital is little younger age. Children will get maximum subcapital. Little older age youngster, transcervical.
Okay. Adults, anatomical classification. In IC fracture. Helbert.
Right. Okay.
Sir. Okay. This is a 59 years old male with 1 month 2 weeks old supracondylar fracture of right humerus with no DNVD, sir. So we have done open reduction internal fixation with K-wire.
Or transcondylar.
Supracondylar.
Really?
Transcondylar.
This is called transcondylar only. See, you can see this. Not supracondylar. Transcondylar, yeah. There is intraocular extension or not?
There is no intraarticular extension.
Can make out in CT scan or you didn't do? Yeah. Yes. But CT scan is not done.
I did not done, sir.
Yeah.
Yes, sir.
6 weeks. 6 weeks. Yeah.
Okay.
Right.
Okay.
Clinically, how is it, the elbow?
There is before operation only
No,
there
no.
was full range of flexions.
Clinically, how did you see the patient coming? How's the attitude? Photograph?
Video on, sir.
Yes.
Yes, sir. Native treatment was present, sir.
Not foreign treatment, native only. Unda. So much is seen newborn there surrounding the complete joint. Is it masseter also on the newborn formation? Idandi left adu mas chodochu. Everything can. Surgery.
Sir, he said the moments were painful, sir. That's the reason.
Aikanda? Why did you do plating for this? Why did you do plating for this? No, yeah, so many plates nowadays, lateral, medial plates, columnar plates are there. Why didn't you choose that? So what? You have gone posterior approach, no? We have gone both sides, can take it. So whatever it is, fixation I am asking. Approach can be anything. Right.
Good morning, sir. These are X-rays from Unit 2. 41-year-old male with 1 week old closed distal and radius fracture with intra-articular extensions. So increased ulnar variance, decrease in the radial inclinations.
Ulnar variance is normal. Only a little impacted with articular extension.
Which column fracture is this?
Intermediate columns. Intermediate column fracture.
Is it a dry punch?
Magnify the
Die punch.
Magnify it, we'll see. Zoom. Right. So it's not.
What is dry punch?
So articular surface near the scaphoid, it is
Scaphoid.
depressed.
Die punch is what?
Lunate. Lunates.
This
The
should impact
depression
here,
of the articular
depression
surface here, it is die punch.
but it's not aware, yeah. Here intractable fracture, that's all. So it's not a other fractures, intractable fractures which are there. Is there a name for it? Is there a name for it? Intractable fracture? No. Volar bar, no?
Barton, sir. Barton. Volar or dorsal Barton.
No, is it there?
No, sir. There's only. No, sir, because there is intra-articular extension. Yes, sir.
Intermediate only, that doesn't matter. I'll put only plaster. I'll leave it. Right.
Then open reduction, internal fixation with plating for right radius. So variable angle locking compression plate.
So much of void there in the lateral view. What is going to happen to the void? Have you improved the position upon the pre-op X-ray? Did you improve the alignment in any aspect?
What age is the patient?
So 41 years.
Did you improve the position or it is same?
So
Polar variance? Polar tilt is still persisting or restored? Almost neutral. Position being the same.
Fixation. Sorry.
Are you immobilizing it post-operatively?
Yes, sir. With the rollers. Immobilized with his below elbows. Like
See, it becomes
3
stiff.
to 4 weeks. 3 to 4 weeks.
If put for 6 weeks, it becomes stiff.
66-year-old male with grade 3 compound medial condyle fracture of left femur with closed middle third distal third junction fracture of right fibula with closed medial malleus fracture of right ankle. This pronation external rotation. Yes, sir. Compound injury on left, sir. Right is ankles. Should be done open reduction, internal fixation with CC screws for medial condyle of left femur, and we did wound debridement. Open reduction with CC screws for right medial malleolus, and closed an open reduction with rush nail for right femur.
Zoom this, we'll see. Where is the fracture here? Malleus. Malleolus fracture is it?
Yes, sir.
2, yeah, put only 1. 2. Up. Scroll it. కింద కాడ మీద పోతుంది అంతే రాదు.
Yes,
లేదు
once.
కట్ అయింది అది ఓకే. ఇదేంది ఇది 2 యా పుట్
Yes, sir.
స్క్రూస్ రైట్.
2 screws.
దిస్ ఇస్ గోన్ రైట్. నువ్వు ఉన్నావా? అదే అంటున్నా.
Yes, sir.
సిక్సెస్ వేసినారా?
Yes, sir.
Open. Open.
So there is combination also, sir, in the fragment. Ligament, deltoid ligament.
What was ligament? Fracture site, what did you see with us?
Sir, there is combination of this fragment, sir.
Fracture site and periacium. Fracture. Look for the periacium which gets into the fracture site. That's what.
Oh. Yes, sir.
Oh, the ideal is, sir.
Yes, sir. Yes, sir. No, sir.
Nothing was there.
No.
Right.
Sir, the picture
Uda?
we didn't take, sir.
Really?
16-year-old male with closed distal third both bone
Hold on,
fracture of
right.
right leg, sir. We have done ORIF with plating for right tibia and right fibula.
16 years, right?
Yes.
What about this fracture is there?
No.
Is it reduced properly? Is ankle what? Is it valgus or varus?
Sir, mortis view.
Hmm?
Mortis view.
No, I am asking about ankle. Is it in varus or valgus?
It's in varus.
Right.
So this is 18-year-old male with subtrochanteric fracture of right femur with peri-implant fracture of right distal both bones.
This is fresh one.
So this
What?
is 4 months old ILN, sir. Now this is a fresh fracture.
Sorry.
Sir, and on left side there is grade 3B lateral condyle fracture of left tibia with proximal third shaft fracture of left fibula. The CT images it shows undisplaced tibial fracture.
What the wound?
Yes, sir.
How was the injury to this? What posterior side the wound is there?
No,
On
sir,
the anterior
not
side.
on the posterior,
Anterior
sir.
side.
Extending from medial to lateral on the anterior aspect.
What type of injury is it?
It is degloving injury, sir. There was no
Degloving.
attachment. Yes.
Acute glowing?
But so
Laceration which is there directly onto the knee. What is degloving?
sir,
Where do you get? Degloving you get in leg completely, or the thigh, or the pelvis, but not at this area which is anterior side, extension.
yes, sir.
Is it the bumper fracture?
Sir?
Is it bumper fracture or not? No, bumper.
No, sir. No, sir. Patient was pillion rider.
That's what so?
Can't exactly say bump.
Something hitting against here, that is not bumper only, need not be always bumper. Any fracture occurring here, it can be bumper, right?
So did open reduction, internal fixation with long PFN and circlage wire for right subtrochanteric fracture. The patient was not cooperating to take a lateral X-ray, sir. We have put only AP. Neutrals.
Right?
Sir, further. Yes. Sir, in interop we checked on the right, the patient was unstable during the surgery. Anesthesia told not to do the second surgery right away. So we
have not
applied
done.
cast for the right ankles.
Mm.
This is wound debridement for left knee, and we applied a slab for the left. There is contamination, sir.
Okay, is it a case for implant removal? Huh? Medial malleoli. Cursor పెట్టు. పెట్టు వెనక్కి పెట్టు. Where is the mortis view before doing surgery and after doing surgery? Go back. 3 of X-ray. What is the need for mortis view? Is there a need or not?
If soft tissue release is correcting the deformity, see what we want a plantigrade foot. So if you can achieve plantigrade foot with the soft tissue correction, you can leave it there. If you cannot, then you have to do bony procedure. Okay, we'll go to the general club. Yeah, you're gone.
What arthrodesis will you use? Only ankle? Or any other joint? There is talonangular arthritis.
Yeah.
Osteophytosis is there.
Yes, sir. Triple.
So for that kind of deformity, I think standard is triple orthodesis. Our simple ankle orthodesis will not correct the deformity.
Okay.
Reduced quality of life, increased burden due to aging orthoplastic populations. Aim is to determine which femoral stem design and fixation method has the lowest risk of reoperation for periprosthetic fracture after primary hip orthoplasty. Materials and methods. Type of study, registry-based observational cohort study. It is retrospective analysis of prospectively collected national registry data from Norwegian Orthoplasty Register and Norwegian Hip Fracture Register. Study period.
So do you know what is a registry?
Yes, sir. They include all
Because some of them may not know. Yeah. Okay.
include all the patient details from clinical pre-op, intra-op, and the follow-ups,
So the way of assessing joint replacement, if they're successful or not, is very difficult. The only way is registry, joint registry. So all the joints, simple data, all the joints are registered. What is the indication, what kind of implant, and failure. So the minimal information is recorded, then based on that you find out whether that process is or that joint replacement successful or not.
Yes. Study period was from 2005 to 2023, of 19 years. Sample size was 1,56,931 patients and 1,87,576 femoral components, out of which total hip replacement are 1,37,806 and hemiorthoplasty are 49,770. Inclusion criteria, sir. Common processes which they included is more than 2,000 cases. Contemporary prosthetics still in current use. ODEP, Orthopedic Data Evaluation Panel rating, greater than or equal to 10A, where 10 is mean duration of follow-up and A is the grade, like it is the standard. If it B, it is acceptable implant. Primary total hip orthoplasty, including hemiorthoplasty also. Complete American Society of Anesthesiologists data. Exclusion criteria is uncommon prosthesis, less than 2,000 cases. Obsolete designs, missing ASA grades. So they have made this study on 5 femoral designs: cemented composite beam, cemented double tapered, cemented triple tapered, uncemented wedged collarless, uncemented wedged and collared. Out of 30,000 cemented composite beams, any cause of reoperation are 1,562, component revisions are 316, and reoperation specifically for periprosthetic fracture is 63. So in all the 5 type of components, reoperation for periprosthetic fracture was more in cemented double tapered stem design. And in uncemented components, wedged and collarless had more number of cases for reoperation for periprosthetic fracture. These are the 5 components which they have classified, sir, and taken into consideration. Cemented composite beam, cemented double tapered, cemented triple tapered, uncemented wedged collarless, and uncemented wedged and collared. Data analysis was done by Kaplan-Meier survival analysis for analyzing the raw data. Cox proportional hazards regression for getting the hazards ratio. Fine and Gray computing risk model for the confidence. Risk is associated with certain tapered and uncemented stems. Cemented component beam stems showed the lowest fracture risk. So this is a table where they have compiled all the data. Cemented composite beam, total stems at 30,415. It is 0.2% of reoperation for periprosthetic fracture. Adjusted hazard ratio is 1. And this 10-year fracture rate is 0.3. Femoral revision any cause is 316, which is nearly 1%. It has lowest periprosthetic fracture risk and best overall performance. Cemented double tapered is 53,255 stems, has 0.8% of reoperation.
You can read the conclusion and give the message.
Oh.
That
So in the cemented category, cemented double tapered has 4-fold risk than the composite beam. Triple tapered and double tapered didn't have much difference for periprosthetic fracture. And cemented composite beam had the lowest risk of periprosthetic fracture. In uncemented category, uncemented wedged and collarless had significant fracture risk, where the collar in the uncemented wedged collared category significantly reduced the fracture risk.
So the conclusion is cemented. See, in a cemented, the stress distribution is equal.
Yes.
Uncemented, because it may not get incorporated.
High stress shielding.
So there will be stress, raises may be distal to the or unequal stress distribution. That's one of the factors. Gone.
This is a graph showing comparison in between all the components with the cemented composite beam. Conclusions. Among 1,87,576 hip arthroplasties, nearly 0.7%, that is 1,398 cases, underwent reoperation for periprosthetic femoral fracture during median 4-year follow-up. Cemented composite beams had the lowest fracture risk and served as the safest reference design. Cemented double-tapered and triple-tapered stems showed similar fold 4 higher risk, indicating no benefit of triple taper over double taper. Uncemented collarless wedge stems had the highest fracture risk, while collared uncemented stems reduced the risk significantly. The collar provided a protective effect, with collarless stems having approximately 2 times higher PPF risk than the collared stems. Cemented composite seams are preferred. If cementless fixation is necessary, collared uncemented stems are best alternative.
Okay.
So this is criticism. The observational designs causation cannot be confirmed. Possibility of confounding variables. Registry data may have incomplete reporting, and they have mentioned not.
So can you do randomization in hip replacement? You can't. And it can be only observational and retrospective. You cannot have a
Randomization.
for this kind of prospective.
Yes.
And of course, so many variables are there. And the data, because of the disadvantage of retrospective studies, data may not be there. What you want to analyze now, that data may not be recorded because it's not a prospective. Though it's a prospectively recorded, but sometimes may be missing. Ajit is here. Yeah, can you comment? You can have the mic.
These days, first data collection is the most important thing, sir. We have to make sure that the data entry is proper right from the beginning so that we don't have these lacunae. That is the first thing. I wanted to also talk to the PGs about putting the patient's face and the pictures here.
From next time onwards, all PPTs should be sent to Ajit. He's here to help us.
Here is a small ethical note I wanted to talk to you about. The X-rays and the CT scans are clearly mentioning the patient's name. And the patient's face is visible when we just saw the video of the patient walking. It would be better if you could mask those data, because these days, these things are becoming more and more common, risk compliance. So that is one suggestion that I had.
Sridhar, any comments on the journal? Come to the front. Bring him. Bhavana, come. Bring him as well. We'll introduce you, don't worry.
Because it's a Norwegian study with that much amount of sample size, we have selected this study. Also, yeah, true, there was no randomization done, but in observational, when you're telling it's an observational result, obviously there's no randomization.
Okay. Yes.
But that was a good one. Last, I think the case presentation also was good. That's, I think it should be, because information is very, very important. The data you collect, clinical data, and so presentation, you have to be. So now we have a visitor, Dr. Bhavana from Mayapada Hospital, Surabaya, Indonesia. He's visiting us to learn about his experienced orthopedic surgeon, but he wants to know what we do. And he's a part-time proctorship. I go to Indonesia for proctorship. I train the surgeons in various hospitals, so they come here to see our places as well. You want to say something about the morning discussion? What, how it was? Was it useful? Or?
Yes. Thank you for the opportunity. Yes, I will say thank you for you, sir, for the opportunity to see how you teach your studies. Okay. Thank you so much for the.
So previously we used to go abroad training, I know even now happens, but now people, various places, they come to us because our work is as good as anybody else. And we are very competitive. The quality of work we do is comparable with anywhere in the world. So that's the way you should aim. That's why I criticized one presenter. Doesn't mean individual. It goes everybody, applies to everybody, not you. So whenever you take one X-ray, you must analyze what questions are going to happen and how you're going to. Each one is different. Because in a rush, middle of the night, just putting X-rays from iPhone or your phone and onto the PPT is not must. Then otherwise don't present it. Present it next time when you're ready.
Can you make a little half an hour early on Thursdays?
I will miss my morning meeting and come here. Okay, no problem. I'll come early. Okay, we'll have a picture come. Because he wants to take home. Come see that. All of you can come. Just
వచ్చినామా అభ్యర్థులు
ఈ పోలకుదో చవాన్ రాజశేఖర్ కట్టు శుభవేళ కాదు శ్రవంతి నీకులేదే
నమస్తే
ప్రొఫెసర్ సంజనారెడ్డి